Professional Affairs Information Technology Committee this morning. We'll start our business with, I'd like to propose the acceptance of our minutes from September. If I can get a proposal for that.
So moved.
Right, all in favor, please say yes. Yes. Thank you. All right, minutes are approved. And let's go on then. We have three presentations this morning, so let's begin with our first. Dr. Techie, if you...
Yes, thank
There
you.
you are.
Good morning. Yes, how are you? We are happy to be here to be presenting this update. So we are requesting authorizing the New York City Health and Hospitals Corporation, the system, to increase funding by $29,922,455, which includes a 10% contingency to its previously negotiated and executed contract with Natera Inc. for prenatal testing services. The cumulative not to exceed value for services provided by Natera shall increase from $15 million to $44,922,455 for the remainder of the contract term, which continues until December 31, 2027, including 2 one-year renewal options exercisable at the discretion of the system. And our Assistant Vice President for Clinical Business Operations, Carmel Melissa Hilaire, will be presenting today, and Wendy Wilcox, Dr. Wilcox, our Chief Women's Health Officer, will be also participating.
Thank you, Dr. Techie. Good morning, everyone. Before we dive in, I would like to start by framing this presentation. And I think it's very important because first, it's a sizable ask. And second, because the presentation centers on prenatal genetic tests, an essential pillar to our prenatal care program. And you see these tests, these prenatal genetic tests, enable our providers very early on to place critical information in the hands of our patients to empower them to make the best decisions for themselves and for their families. And equally important, these test results guide the pregnancy and medical management of our pregnant mothers and their little babies. So, with this in mind, the question today really becomes how to right size the Natera NCE. So, why are we here today? What's the issue? While we were monitoring the contract spend, we've noticed that the disbursements were quickly outpacing the NCE value. And this is because the cost of carrier screens was not included in the original financial projections. The issue was flagged, and I have been working ever since with our internal partners to craft this proposal to address the deficiency, bring us into compliance, and ensure that we continue to deliver standard care to our patients. So today, we are here because Clinical Services Operations is requesting approval to increase the not to exceed amount for our prenatal testing contract with our current vendor, Natera Inc. Our prenatal screening program is designed around the offering of 2 key tests. We offer non-invasive prenatal tests, or NIPS. And what that means is that we analyze the fetal DNA to detect any chromosomal abnormalities that may cause Down syndrome. We also offer carrier screens, and the concept is the same. This time around, we test the parent's DNA either before or during pregnancy, and the goal is to identify any hidden genetic mutations in a select number of genes that could put a child at risk of a serious condition. Carrier screens are a safe, effective, evidence-based tool that are now considered part of routine care. In fact, by offering these tests, H&H aligns with both the New York State Department of Health and ACOGs, which recommend offering this test to whoever is pregnant or considering pregnancy. Next, please. NIPT and carrier screening services were procured through a competitive RFP process. The procurement was approved by the CRC in August 2022 and approved by the board in November of the same year with an NCE of $15 million. The contract includes a 3-year initial term and 2 one-year options to renew and will expire on December 31st, 2027. The contract spend through August 2025 is $18.4 million. If there's one thing that I would like for you to remember is that non-invasive prenatal tests and carrier screening are both reimbursable by third-party payers. A conservative payment estimate for the top CPT reimbursed shows that we've collected 24 million for the period of calendar year 23 through July 25. I'm fully confident that revenue collected will offset the cost of the contract. Next, please. Clinical Services Operations is requesting approval to increase the not to exceed amount by $29,922,455 for prenatal testing services. There are two reasons that support the need for this increase. First is the inclusion of the cost of carrier screens. So while the carrier screening was included in the RFP and in the executed contract, the cost of these tests was not factored in the original projections. And there's a good reason for that. It's because at the time the volume was pulled, we did not have a fully functioning interface in place that allowed us to capture the utilization across the system. And second, the demand for NIPS exceeded the original forecast. So when looking at the table below, you can see that we've exceeded our NCE value by 3.4 million. The projected spend based on utilization alone for the period of July 25 through December 27 amounts to 24.1 million. We've added a 10% contingency buffer based on the utilization, which totals $2.4 million. This brings us to our total NCE increase of $29,922,455. When adding that NCE increase to the original NCE amount of 15 million, this raises the contract value to $44,922,455. The vendor performance, as you can see at the bottom right, is rated as very good. And next, thank you so much. The vendor diversity is not applicable to this contract because there were no scopes that could be subcontracted under this solicitation. So we are here today to request committee approval to authorize New York City Health and Hospitals Corporation, the system, to increase funding by $29,922,455, which includes a 10% contingency to its previously negotiated and executed contract with Natera Inc., Natera, for prenatal testing services. The cumulative not to exceed value for services provided by Natera shall increase from 15 million to 44,922,455 for the remainder of the contract term, which continues until December 31st, 2027, including 2 one-year renewal options exercisable at the discretion of the system. And I would like to end with 3 key points. First, I think top of mind for us today is that we need to continue to provide standard care to our patients. And adjusting the NCE value will allow us to do just that. The second point to consider is that the facilities are already incurring these costs because we've been providing these tests. And third, the investment will pay for itself. Thank you.
Thank you. Yeah, I think that last point, and it makes it a little difficult, I think, sometimes to be able to absorb the information, particularly when we're saying an increase spend, when in fact there may be offsetting. From what you have so far, top diagnoses, it looks as if it's basically fully compensated. We're getting
Absolutely.
actually. So, which is difficult, again, to sort of absorb because we're asking for additional outlay of dollars, but in reality, we may not be. It may be actually offset. And the bottom line, and the most important thing, I think, from what you said, is this is really the standard of care now. So for example, when we do have families identified in the testing, for carriers, that is something I imagine happens once, and then obviously it carries through, so it's a
That is
one-time
correct.
expense. And I would imagine from the counseling perspective, remind me, because I think at one time I remember, Natera does supply some of that counseling, we supply some, or how does that work as far as the counseling for those that are positive when we do?
We have counselors at all of our sites, and patients are referred if they need it. And certainly, if there are any questions, like sometimes the counselors can call Natera, and they do have expert services available.
Yeah, that was my recollections, which I think is very helpful, so. All right, let me ask anyone, any other questions or comments?
So that, Medicaid pays for it?
Yes,
Yes.
Medicaid pays for both?
yes.
That's it, thanks.
Any other questions? Sally Pinheiro did have a question, which I'm trying to sort out, but I think what she was looking at was looking at the estimate of what we actually do get compensated from the amount that's billed and comparing it to the ask, which was about 24 million. And I think she was just confused about, but I think you pretty much explained that this is our estimated collection.
Correct.
So I
And that's
think
a
that
very
was-
conservative estimate. I'd like to reiterate that.
All right, so then if there are no other questions, let's vote. Dr. Martone?
Yes.
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 Dr. Spiritu, okay. Motion carries. Thank you for the fabulous presentation. It was really great.
Thank you.
Thank you.
Thank you.
All right, let us move on then to our next presentation. Dr. Long, you
Yes.
to the record and give our presentation.
Sounds good. I'll read the request and I'll pass it over to Senior Assistant Vice President Chris Keeley to go through it. So for today, our request is authorizing the New York City Health and Hospitals Corporation, the system, to execute contracts with Rapid Reliable Care NY by DocGo LLC, AC Disaster Consulting, Premier Assist LLC, Cherokee Nation Management and Consulting LLC, and MedRight LLC for public health rapid response services at a not to exceed amount of $75 million for a contract term of 3 years and 2 one-year renewal options exercisable at the discretion of the system. With that, I'll turn to Chris.
Dr. Long. So what we're looking to do here. So in order to respond to significant threats that infectious disease outbreaks can cause to health and safety of New Yorkers, we're looking to contract with multiple vendors so that there's redundancy, because this would be an emergency response capacity. We're looking to contract with multiple vendors for citywide mobile testing, treatment, and vaccine services during outbreaks, including things like COVID-19, Mpox, measles, tuberculosis. The pooled contract will ensure that vendors are pre-approved for the emergency response. That way we don't need to try to contract in the midst of an emergency response. That's one of the lessons learned coming out of COVID. When we needed to try to build that capacity, we were already in the emergency moment. So what we want to do here is have some contracts available to us. We won't spend on them unless we get authorized, and we'll talk about that in a moment. But we just have the contracts available. We contract through a process like this, through the standard process, and then if there is an emergency, the capacity is available if we want to tap into it. The scope of work for these services is modeled on that successful mobile strategy that we used during COVID-19 and Mpox, where health and hospitals played a critical role in supporting the city's public health response. The pricing for these services is primarily based on a per team, per day basis. In the event of activation, vendors are expected to deploy 5 or more teams operating 5 to 7 days a week, starting very quickly, starting immediately after activation. Deployment can last anywhere from 2 to 4 weeks for smaller or 4 months or more for larger responses. The mobile services can include medical care provided from units like Sprinter vans, tents on a sidewalk, teams set up in a church or mosque basement. The vendors will be responsible for staffing, patient notification, mitigation planning, response logistics, data and reporting, and daily coordination. Importantly here, in this sort of setup, again, this is a setup we've used a number of times over the last few years, the patients here are not health and hospitals patients. The patients are not going into Epic. These are the patients of the vendor, of the contractor. They're patients that are living in their EMR, not ours. The vendors will be expected to meet performance KPIs, including mobilization time, response time, and provide all reporting. These will be managed by existing staff. No additional internal resources are needed or expected for small to medium responses. If there's a larger response, then we would seek out additional resources if needed. Vendors will be assigned work based on their expertise and capacity. There's no minimum expectation here. There's no work guaranteed to any vendor under these contracts. It's at operational discretion of how that gets assigned out. Whatever the response size needed to use these contracts, health and hospitals will require written authorization from its president and CEO to activate operation. Health and Hospitals Board and OMB will be informed of that President CEO approval, and OMB will be asked to provide agreement to cover incurred costs prior to vendors beginning services. Again, prior to vendors beginning services, we seek that OMB approval. The NTE here, the 75 million you saw there, that's calculated on activations of 16 teams per day for 120 days per year for each of the 5 years in this contract. 16 teams per day, 100, so 4 months a year for 16 teams for each of the 5 years. Vendors are only paid for activation time. There's no retainer for any of the vendors under this setup. And again, as I said, no minimum work is guaranteed. References checks were completed for the vendor that was new to the system. You see here the criteria: minimum 5 years in business, $10 million in annual revenue, 2 years of relevant experience, and MWBE plan. Substantive criteria you see laid out there, as well as the evaluation committee. Here you see the timeline going to CRC and posting to the city record in July. In August, we had the pre-proposal conference call, and proposals came in. We had 9 vendors on both that conference call and 9 proposals submitted. Bless you. In September, the evaluation committee met and submitted scores. You see here the top 5 scorers that were listed at the beginning by Dr. Long. You see here vendor performance for this in the next few slides. Each of them you see at the bottom there are marked excellent for those that we've worked with in the past. Here on the vendor diversity slide, you see the vendor diversity team recommended a 30% diverse vendor component. Each of the vendors here would either be an NYC MBE itself or WBE itself with a 100% goal, or having a plan to get to the 30% recommendation from the vendor diversity team. So as Dr. Long said at the beginning, we're requesting authorizing the New York City Health and Hospitals Corporation to execute contracts with Rapid Reliable Care NY by DocGo, AC Disaster Consulting, Premier Assist LLC, Cherokee Nation Management and Consulting LLC, and MedRight LLC for public health rapid response services at a not to exceed amount of $75 million for a contract term of 3 years and 2 one-year renewal options exercisable at the discretion of the system. Thank you.
Thank you. Again, one of our board members, Sally Pinheiro, had a question, which if you could address. She asked basically, this is a very large outbreak we're discussing here, and the question she had was, well, what about small outbreaks? And the other question she had was, did we end up using this many vendors? So maybe if you could give some of the experience from the ramp up with COVID and how well and effective this was, and I guess what about small outbreaks, and are we anticipating any, let's say with the Mpox or something, do we anticipate any of that coming at this stage? So
Sure. So I'll say a few words, and I'm sure Ted has a few things to add as well. So as sort of our either end of the spectrum so far from our experience in the last few years, a smaller outbreak that we used this sort of capacity for a few years ago on Mpox, we were using maybe half a dozen teams at a given time. That went on for maybe 4 months.
Yeah.
And so we were using 6 teams. The NTE we're modeling out here is 16 teams. So we were using 6 teams for about 4 months in that scenario. In COVID, I think our peak was about 130 mobile units out on a given day, and they were operating about 12 hours a day, 7 days a week for 15 months, well over a year. So those are sort of 2 ends of the spectrum. What we were looking at doing here was sort of, what does it look like to have a series of sort of medium-sized responses? So about a 4-month response, 16 teams, every year for 5 years. We hope for New York City's sake we don't need to use that, right? We hope that we won't need to use this contract at all. The hope is that we do this now and we have it available to us should we need it. But in terms of anticipating what the usage might be, Dr. Long would know better than me, but I don't know how to anticipate that in advance.
Yes, 2 thoughts. I mean, one, I think the success we've had with this structure, Mpox is a good example of that. So we developed the structure as a lesson learned from COVID. And then when the Mpox outbreak began, we heard from community members that there was an immediate need at high-risk venues at literally, kid you not, 2 in the morning. So because we had that structure, we were able to mobilize almost immediately and be at these venues at 2 in the morning, building trust. And at some of these venues, we actually administered the Mpox vaccine to 60% of all people entering these venues, literally at 2 in the morning. Because we had the structure, we could go fast, and we were working with our communities, and we were able to make that commitment to them. They tell us where to be, we will be there. Then the second part was, I think I totally just agree with Sally Pinero. The best way to be prepared is to anticipate for anything. And here we're even listing out some of the things that we are potentially anticipating for. But this is building on the success we had. There's a lesson learned from COVID, the success we had for Mpox, to make sure that we could support our cities we have for the last 5 years being ready for anything.
Ted, on the ready for anything, most of your discussion is about infectious disease. What if it's flooding? What if it's terrible air quality? Are we fine for these contracts to go into effect?
So the system currently has a contract for emergency response activation sites. So those could be used in a number of different scenarios. They could be used for a hurricane or other sort of widespread evacuation scenarios, even a large fire, for example. If there's individuals that need more than what a typical shelter might provide, but less than what a hospital would provide, the intent of that contract is to have that in-between capacity so we could, in effect, set up that field clinic at a high school gymnasium, for example. So we would be able to have that capacity available to us. Similarly, that contract also allows us to provide for very short order response for isolation and quarantining at hotels or other settings if there is infectious disease, going back to that scenario. So that contract allows us a good bit of flexibility to be able to respond in a variety of settings.
Okay, so not this contract, but that contract.
This complements that contract.
That's
So
right.
this is you could view this as the mobile response.
Okay.
Other questions?
Yes.
Dr.
Could you
Martin?
just clarify which is a new vendor? I was trying to identify.
Sure. So the new vendor on that list is, it was AC Disaster Consulting.
Thank you.
How do the vendors survive when there are no disasters? And what I mean is, like, there's no retainer fee, right?
That's right.
So, like, how do they staff or have the equipment, ready? Are they able to respond right away? I was trying to understand that part.
Yeah, so I can speak to that a little bit. So a few of them, they're if we could stay on one slide, Rapid Reliable, MedRite, and Premier. The three of those are urgent care, medical urgent care companies. So they have a number of different sites. They have a bench of staff. They already have sort of a supply chain infrastructure that's in place, and they're all local entities. So that's sort of one bucket of the partners that we have here. Another bucket that we have, Cherokee Nation Management Consulting, AC Disaster Consulting. They're used to sort of, you get the call about a hurricane and they need to deploy in 3 days, and they pull in staff from all over the country or locally. They have supply chains that can respond in the middle of a hurricane, all those sorts of things. So we have some that might be the more local, quick response, nimble, and then some of the other ones that are sort of the more hefty response depending on the type of response we need. We have a variety of vendors here at our availability if this moves forward.
Just to make the point that's why it's important to us to have the variety or the set of the 5 of them here, because each has different capabilities depending on what moment we're in.
Thanks.
Any other questions? Okay, well, let's go to a vote. Dr. Martin?
Yes.
Dr. Pagan?
Yes.
Dr. Katz? Yes. Mr. Spiritu? I'm a yes as well. Yes, unanimously for something I hope doesn't happen. Fabulous preparation.
Well said.
All right. And Dr. Long, if you can,
Yes.
you are next as well.
Pleasure. Okay, so I'll read our next request, and then I will pass the baton to Dr. Stephen Pulitzer. Authorizing the New York City Health and Hospitals Corporation, the system, to execute a contract with Lenox Hill Radiology and Medical Imaging Associates, PC, for outpatient radiology imaging services at a not-to-exceed cost of $12,228,746, which includes a 20% contingency, for a contract term of 3 years and 2 one-year renewal options exercisable at the discretion of the system. Dr. Pulitzer.
Thank you. Thank you for having me present today. So just wanted to give a small summary of the presentation before I give the presentation. We currently contract with a vendor to provide studies that we cannot perform here in the volume we need them, and they are subspecialty exams for PET CT for cancer patients and advanced cardiac imaging for patients with advanced cardiac disease. And what we're asking for is to expand on that contract and allow sites who currently are not using that vendor to have access to that vendor for their patients. And so as I go through it, just to keep that in mind. So thank you. So we're seeking to contract with a qualified third-party vendor to provide enterprise-wide supplementary radiology imaging services. The resulting contract will be available to all New York City Health and Hospitals facilities and patient populations. The imaging services have the following goals. So we want to provide all patients' populations a consistent level of access to PET CT and cardiac CT and MRI and other advanced imaging procedures such as breast MRI when needed to minimize the potential risk of extended wait times while the health system builds capacity to offer these exams internally. We want to establish a clear governance mechanism to decide when and where the external third-party service provider should be engaged for in-scope services, and a vendor clinical and operational performance standard to make sure that we're meeting the standard, and to track radiology services that are referred to the third-party service. Contracting with the third-party provider will help address long wait times for in-scope advanced imaging procedures resulting from new patient growth and new capacity limitations at some of the facilities. New York City Health and Hospitals would activate third-party referrals when patient wait times extend beyond our target turnaround time objectives. The future external referral volume will reflect the actual patient demand for those exams. The vendor contract is a bridge for New York City Health and Hospitals Enterprise Radiology to build the infrastructure to provide the services on-site at our acute care and outpatient imaging centers. Currently, we have active planning for 2 additional PET CT machines across the system, which will open access. And we are currently building a cardiac MRI program, which should go live in January of next year at one of our Gotham outpatient sites. So for background, the current vendor is Lenox Hill Radiology and Medical Imaging Associates. It's a RadNet-affiliated imaging center. In 2018, in February, the contract was originally awarded to the vendor. The original contract expired on December 31st of 2024. A 4-month extension was approved by supply chain in December of 2024 and extended the contract through April 30th of 2025. A deviation memo was signed by Dr. Katz in April of 2025 for $2.4 million, extending the contract through April 30th, 2026. The total contract spend from February 2018, from inception, to September 2025 is $4.3 million. The projected annual spend for 2025 is $840,000, as that is primarily at one site. And to date, the site that is using it is Bellevue Hospital. So we can go to the next slide, please. So I just wanted to define a couple of terms because there is one unique thing about this contract. The contract value that, the total value of the contract includes the amount that H&H pays to the vendor plus the amount that the vendor bills for that contract. And in 2024, that total amount was $1,774,000. And this is based on $816,000 being spent by the health system. So on average, we pay for approximately 46% of patients, the total volume of patients who go to the vendor to be imaged. So if we look across at the graph, what it shows for 2026 through 2031, if we look at the first column on the left, and we go down to the budget subtotal, we anticipate with our current spend, with our current rate, if we only stayed with one hospital, we would be spending approximately $4,849,000 over that time period. If we open this contract to the additional hospitals and outpatient centers who might have need, that contract amount that we would be responsible for would go up to $10,190,000. And we're adding a 20% contingency of $2,038,000 for a not to exceed amount of $12,228,746,000. So just one caveat, the number for 2026 is low because that is only anticipated between January and July of 2026, which is a half of year value.
Stephen, why does it go back? Why does it drop so much between 30 and 31?
I think it's also the same ending in mid-year.
I see.
So it's only a half a year
Okay,
value.
that would make sense. And say a little bit more, because these kinds of contracts are always an issue. How do we make sure that patients are not being billed while we're paying? Right.
Correct. So on the next slide, I have that.
Okay. All right. Good. That's good.
I knew you were going to ask that. So, okay. So for uninsured patients, the vendor, we have a contracted rate with the vendor, which is at the current moment is the Medicaid rate that we would bill for that patient. We do keep track of which patients go there before they are sent, of who has insurance and who does not have insurance. And the insured patients are then billed by the carrier at the carrier's rate, not at our rate. So if there is a shortfall in the patient's insurance, they will contact the patient and let the patient know that their carrier will only cover X amount. The total amount of this exam is Y, and your difference is X minus Y. So they will have them sign a waiver prior to the exam, which then gives us another opportunity, if they're not going to get the exam, to talk to that patient and see if we need to cover that exam ourselves. To date, we have not had that issue, but that is where we would be able to intervene. And then if in the event there is a delinquency on either a copay or an amount that was in excess of what the carrier paid for the privately insured patients, the vendor will treat them as their own patient, will go into collections with them. In private conversations with the vendor, they look at this on a case-by-case basis, and if there is the ability to discharge the amount owed, they will look into every way that they can do that. That's not guaranteed, though. So don't know if that answered the full scope of the question.
Well, it's a complicated and in some way not entirely satisfying issue, but it's not your fault. It's the fault of the overall medical system. So if I understand this, for one thing, we're going to pay for some people more than Medicaid.
Pay for some people.
We're gonna pay a rate higher than Medicaid for some of our patients.
No. So
I'm looking at the part where it says negotiated rate must be between the applicable Medicaid and Medicare fee schedule.
Correct. So it right now that negotiated rate is the Medicaid rate. So we're not paying above that.
I see.
That was the language in the contract.
I see. Okay. Well, I think for the board, it's important to. It's fine if it's in the contract, but if what we're paying is the Medicaid rate, certainly I feel better about that. I think the question of how we deal with insured patients is always a problem in health and hospitals. Because on one hand, we're a mission-driven organization that feels that costs should not interfere with people getting the correct care. On the other hand, we are essentially subsidizing insurance companies and enabling them to provide inadequate reimbursement for studies, right? So if we as a system say, okay, no problem, if it's $1,000 study and you only pay $100 and the patient can't pay $900, no problem, we'll pay that. But it's their job to pay that. It's not our job to pay that for the insured patient. The insured patient has insurance. If the amount is prohibitive for the patient, that's because the insurance has a problem, right? The insurance is not adequate coverage. And so it becomes a very, unclear thing, especially when it's money out the door. It's, if it's our MRI machine, right, and it's just sitting there, it's a little less uncomfortable, right? The possibility that somebody is not going to be able to pay their copay, which I talked to a friend over the weekend with Cadillac Insurance with the cardiac echo that his doctor recommended he has to pay $500. It's like, well, he can pay $500. But is it really worth $500? I told him no. I said, I think it's an unnecessary study. I don't think you should pay $500. So people can get very large amounts is that our job to subsidize it? It's a very hard question.
So just for clarity for me, I'm a little confused. So are we saying that an insured patient, we might wind up paying more for them than we would for the uninsured at the CMS rate?
No, for the uninsured patient, we pay Medicaid. The issue comes in, what if for the insured patient, they have a $500 bill, because, like my friend, and they say, well, gee, doctor, I'm not going to pay I don't have $500 to pay it. Then what Stephen was saying, on a case-by-case basis, we say, well, you need the study, we'll pay the $500.
Instead of saying we'll pay only
Oh,
what they've already
well,
paid
we're
for
assuming
your
that
insurance
would be
plus
less.
whatever equals CMS.
Yeah. Well, let's for the sake just assume it's less. It should be less. The copay should be less than the Medicaid rate.
Okay, because that's
But even then, you still have the same issue. You know, do we pay $500 to Lenox Hill to do a study for an insured patient?
no. So my question was, should we not be paying the difference between, let's say CMS is paying $2, and then let's
Oh, I
say
see what you're saying.
right, and then let's say that person's insurance paid $1. Do we pay $1?
Stephen?
So so I think in this situation, what we would do would be to treat them as a self-pay, and treat them as somebody who was uninsured for this situation, because I don't know that we have the mechanism at the moment to go in and pay the difference. Now, ideally, if the difference was less, as Dr. Katz had said, that would be a better option for us. If that patient needed that exam and we could not provide that exam in any capacity here. If the patient is getting this exam because we are over capacity at some of our other sites, we then also have the opportunity to try to move that patient into one of our other sites and get them imaged sooner. So we do have a decision tree. Luckily, to date, we have not had to use the decision tree, but it is there if it's needed.
And just in one other important point, because your point's really a good one, going back to what Mitch said, if it's our MRI machine, it's less of an issue. That's the general direction we want to go in here. So I don't want to steal Stephen's thunder, but we projected numbers up to 2030. We hope to not get to that point. We hope to, in the next couple of years, bring as much in-house as possible so we avoid the tricky situation you're outlining.
Yeah, I hope we can get to the point where we can negotiate something where we just pay that difference up to the CMS rate and not beyond that, or
Yeah, or even better than that, not even have to use
Yeah,
a third
well,
party.
that would be the best.
Yeah.
The future, I mean, and Stephen knows this better, it's a little bit mixed. On the positive side, the machines are getting faster. Right.
Yeah.
The MRIs in particular are getting faster. And that will enable, more studies to be done. I think the negative on the future is that there seemed to be also a proliferation of tests.
Right.
And in a sense, on some basis, this kind of contract makes sense, right? Which is, rather than buy new equipment, use somebody else's new equipment where they have excess capacity, right? And then, in fact, the failure to do that is one of the things that drives up costs, is each hospital has to have their own PET scan, right? And while it would be a better use of money if you used the excess capacity in everyone's PET scan. So it's not I think it really depends how much, the volume, you're going to be, I have no doubt, and Stephen's done a phenomenal job organizing our radiology services. I have no doubt that you will be doing more of our own studies. I'm just not sure what the total denominator will be in 5 years. Right, that could it be that the total denominator of what becomes standard studies grows up faster than you can bring things to health and hospitals? Then regardless, that won't be your fault.
Right.
That's just what the environment is bringing.
Yeah, changes in screening, for instance, in breast cancer.
Yes, excellent example.
Giving more MRI for patients with dense breasts and screening at younger ages. And so that will outstrip our capacity.
Right. Prostate as well, right, because of the fact that CT not very good.
Right.
So then you have to go MR, right, which then increases the amount, right? The CTs have gotten very fast,
Yes.
Right. When I remember as a resident, we used to go to put people in the CT scan. That'd be like 30 minutes.
Yeah.
Right. To do this now, zzz, a minute and a half and you're out.
Yeah.
But the MRIs they're getting better, but it's still, time.
Right. Yeah, AI has cut down on the time with those tremendously, from like 20 minutes to maybe 10 minutes. So,
Yeah. Yeah. And maybe in 5 years, it'll be 4 minutes.
Right.
Right. I mean,
Yeah, but I think that just to link these pieces together, the concept here is this gives us the flexibility to do what you're saying.
right.
We'll see what makes sense to Dr. Martone's point, to bring as much in-house as possible, make sure we're using all of our resources, as much as we can, and as it makes sense, this gives us that sort of overflow in a reliable way, so our patients get uninterrupted care.
Right, and it does seem like, strangely, in this instance, we are better to send the uninsured to Lenox Hill, pay the Medicaid rate, and keep the insured patients where we'll get partial payment for it.
yes.
And then we cover the other the way we do for any self-pay patient. And that way it's not dollars out the door for us. So such a crazy healthcare system.
I didn't want to say that too loud, but
Yeah.
yes.
Nothing wrong with
Well
that.
said. No,
We're providing
Absolutely.
services to everybody. There's nothing we're just figuring out. We do that every day. We figure out everybody gets the service, but where they get the service should in fact depend on, how we keep the system alive.
One quick question relating to the reports, because they don't use Epic, correct? I'm just wondering, how does the report get to us? Do our doctors get a chance to be able to view actual films? Are they seeing only reports? And if they're not using Epic, is there any way we can interface somehow? Is that being looked at?
Yes, so there is actually an electronic way that we're putting in place now between our hospitals. And yes, right now the reports can get faxed, but there is a PowerShare, it's called. And so that way we can actually get view the images and the reports at the same time.
And won't they be on Epic within 15 months?
That I'm not sure.
I mean, they're certainly in the implementation phase.
Yes. So, we had a call with them last week, just to be forthright, but and they are actively in their Epic phase. So they will be on Epic. We will have the ability to share reports, Epic everywhere. So just that exact date. But as a bridge, we will be using PowerShare.
I mean, I agree they don't have Kim or Michael, so it's not gonna be as good or as fast, but still at some point they should achieve it.
Just on this one, the reports we can get down from a portal today, a little bit better than fax, but some of them do come across that way. Yes, when they go live with Epic, we're definitely going to be able to have the reports available day one. Now I'm talking Steve's language here. There's reference quality and there's diagnostic quality images. The reference quality images will be available through Epic when they transition. Diagnostic is what he was talking about with Microsoft PowerShare, which is a separate way to transmit images. But basically the long-winded way of it, this is very possible to get both the images and the reports back and forth between the institutions.
And in Montauk.
Yes.
And as far as the quality control and the reports and all, is that something we do, or is Lennox doing it? How do we kind of have the quality assurance on the reports?
So to date, actually, we don't do like an OPPE for the providers because they're not credentialed with us. So it's really looked like as an outside, a referral outside the system to a third party.
And hospitals are not directly sending, right? These are all ambulatory. These are all outpatient.
They're all out.
No inpatients, right? Yeah, all ambulatory.
All right. Other questions? Otherwise, we'll get to the vote. I apologize. I know we're running quite far behind, Dr. Martone. You might as well also vote at the same time. Yes, that was a yes.
Voting now, okay.
Yes. Mr. Pagan, yes.
Yes.
Yes, and yes, another yes, unanimous approval.
Great.
Thank you so much.
Thank you very much.
All right, let us get on now to our reports. Chief Nursing Officer report, if we can go first. Dr.
Good
Sinead.
morning. I'm pleased to present that we have launched the inaugural cohort of the Nurse Educator Fellowship Program in partnership with Mercy University the first of a few cohorts made possible by the Mother Cabrini Health Foundation. 10 nurse educators will be able to complete the Advanced Nurse Educator Certificate Program. Thank you. Next highlight. So the second highlight is our Nursing Clinical Ladder Program. We held a celebration on September 16th. Next slide, please. We are proud to share that out of the 930 participants in 2024, we featured 13 exceptional clinical ladder projects. In 2025, we've seen an uptick of the number of clinical ladder participants, so we're really proud of the professional development aspect of nursing and the proliferation of projects and just the dissemination of work that's happening internally here at New York City Health and Hospitals. Next slide. And the third highlight is our new neonatal intensive care fellowship program to support new graduate nurses interested in working in the neonatal ICU. This is a groundbreaking program to support newly licensed nurses build the specialized skills, confidence, and resilience really needed to care for our most fragile patients. Next slide. This is a photo of Kimberly Campbell-Taylor, our Director of Simulation for the system with our new fellows. The next six slides demonstrate internal and external celebrations of our nurses accomplishing Pathway to Excellence with distinction. We're really proud of our nurses and the leaders at Metropolitan Carter walking the national stage in Georgia this past October. That is Carter. Next slide is Metropolitan. We're really, really excited, and that is Carter, first LTAC across the country to receive this designation. Next slide. And that is the Metropolitan team. Next slide. We're also really proud of 3 sites that have been able to present externally evidence-based practice projects, poster presentations at this conference as well. So Metropolitan, South Brooklyn Health, and PAC were all able to present their work. Next slide. That is PAC at the poster presentation. Next slide, and that's all of us really celebrating our amazing work. Really proud of all of the nurses and nurse leaders disseminating our work externally. Next slide. The last 2 highlights, the next highlight is our Doctoral Circle of Excellence. Just to give this context, nationally there are less than 5%, I believe it's 2.7% nationally, of nurses who have their doctoral degrees. And so we held our 4th annual Nursing Doctoral Circle celebration. We now have 162 nurses with their doctoral degrees. We're really excited about this because this is a culmination of PhDs and DNPs and EDDs who are now subject matter experts within our system who are able to conduct nursing research and also evidence-based practice projects. Next slide. This is all of us. I want to thank Dr. Katz for his support and just really encouraging nurses to receive their terminal degrees in nursing. So that was our celebration on October 14th. The last highlight, respiratory therapists often report to nursing at our facilities, and so we held our 4th annual virtual celebration for Respiratory Care Week on October 20th. We had a large number of RTs join the celebration. We had the president of the American Association of Respiratory Care, Dana Evans, join us, and I received a lot of emails from our RTs just thanking us for their support. And that concludes my report. Thank you so much.
Thank you. Any questions or
Just
comments?
a comment.
Dr. Martin?
Congratulations on the number of DNPs that you have. I think that's wonderful, and I think you leading that effort is excellent. So thank you for that. And congratulations on your magnet journey.
We have 2 sites that have applied for magnet. We now have 5 Pathway to Excellence sites, 2 with distinction, 1st and 2nd in the nation. So thank you so much. We're so proud.
Congrats.
Any other comments, questions? Thank you for a fabulous report. Thanks again. All right, Dr. Long.
Okay, I don't have the pictures that Natalia had, so it's not going to be quite as exciting, but we have hit a very important milestone that I want to share with you all today. So about almost 8 years ago now, we put a focus on primary care and we began to track primary care numbers. When we started to look at this, we did a retrospective, so we were able to track the data back to 2015. So this is what it looked like back in 2015. We had 453,000 unique patients in primary care in our system. The problem was, and if you just focus on the left-hand part of the slide, this is daunting. Every year we're losing 2, 3, 4, 5+% of our patients, like clockwork, and it wasn't going any other direction but down. I think the most important thing I'll tell you is that there's no one thing we did to cause what happened on the right-hand side. It's really the totality of everything that all of us in this room have done over the last 8 years to cause this change, ranging from, even in the first year or two, we cut wait times down by 50%. That created a new door people could actually come through to get care in our system. We started NYC Care, which treated healthcare as a human right, made people feel like they deserved healthcare for the first time. Throughout COVID, I think people had a different experience. I can't tell you the number of people in my clinic in the Bronx that tell me the reason they're there when I see them as a new patient is because they had a great experience being tested, being vaccinated. They said, why not come here for primary care now? Then they go and tell their family members.
Ted, I think in some ways it's important for people to know it's really a little bit more impressive because the drop is real and the increase is real, but the figures before 2018 or so are not real. I don't think that was really the number of.
These are, yes.
Right. Because part of what happened is you set a more sensible definition of what it meant to be our patient, not just like coming one time. And so I don't think it was really true that there were 453 unique primary care patients in 2015.
You're 100% right.
There may have been 453 unique patients, but I don't think they were impaneled or.
No, they were not.
Right. So that there was a lot of urgent care going on is not really the issue. The issue is whether or not you're providing, what you are providing now, which is empanelment, right, and the tools that make clinics stronger. But it's still true that it was going down.
Better.
Right. Then you corrected the numbers so that we would have a true baseline that we could work against.
Right.
Of people who were impaneled. And since we set a true standard, then we're going up. And that's the important part.
Yeah, so these are conservative numbers, but I didn't want to,
I understand, but it suggests that, part of why I don't like it is it suggests that in 15 we were serving more people than in 2025. And I know that's not true.
Yeah.
I know that that's just a figment of how the data were shown in that time. Well, obviously, we can't clean up old data. It is what it is.
It is from QuadraMed, and to the details on it, thank you for asking, Mitch. There were actually part of the calculation visits that weren't primary care. I think even some lab visits in QuadraMed, even if you didn't see your doctor, were included. So this is a very, very, very conservative way to look at it. But even with this very conservative view, the key point is today we have more patients in primary care than, let me use my words carefully here, in the recorded history of our system. Drop the mic. And one more quick slide on this, because this was, what we viewed as such an important accomplishment. Again, I just feel gratitude to everybody here for, and all the support that you as the board have given us to help us to get to the point where, 8 years ago, this was the reach goal that we'd ever be able to get here. And today we've, again, exceeded our reach goal. We've turned the direction around. We have more patients here than ever before. One just quick balancing measure, as always, is important. I think you might wonder, well, okay, so there's more new patients coming in. What's happening to your quality of care? Is quality being sustained? Is it being improved? Is it decreasing? So just one more quick slide here on quality for diabetes. You can see from the quality point of view, not only have we retained quality, but actually quality is the highest it's ever been as well. So not only do we have more new patients in our system, not only is healthcare a human right here and is access to care improved significantly for all New Yorkers without exception, but the quality is the highest it's ever been. We recently on the hypertension side got an award at Morrisania, the clinic where I practice, where our hypertension control is 86% of all of our patients with high blood pressure have good control today. We got an award saying that we had the best blood pressure control in all of New York State. So with that, thank you. That's a maritime.
Great news. Metro Plus, Dr. Schwartz.
They want to just do it with no time.
Morning. Skip the slides to stars. So this slide just talks about the changes in the stars measures. Next slide. So for 2026, we are at 3.5 stars. Unfortunately, we missed the 4-star cutoff by 0.05 points, but it is what it is. Just for the committee, about 60% of Metro Plus members who have Medicare receive their services at H&H. So when we report on improvement, it's truly a testament to their experience both with us and the care that they receive
at health and hospitals. Although we missed the cutoff point, we've seen significant improvement for 2026. So you see on the quality improvement, we improved on 21 out of 45 measures. We declined on 5, but that's a small number compared to the 21 increase. We also improved on our Part D, the medication adherence. We improved operationally, specifically looking at percent of people who are disenrolling, so we have much better retention. And an area that is particularly tough for downstate is patient satisfaction. And it is significantly driven by their experience with the care providers. And so we're very proud to see that there has been a meaningful improvement on the CAP score. Next slide. And the CAPS then had a significant impact on our total performance. And what Ted just presented actually resonates with what we're seeing here. People are coming here. People are getting services. They're waiting shorter periods of time. They're also waiting less time to be seen. And so all of that is actually then captured and reflected in the CAP scores. Next slide. I'm going to skip the membership. I want to go to the call center. So the bottom line on the call center volume is that we've seen the decrease in the call center volume because we're more proactive. We're more proactive in addressing people's questions. They have automated reminders. They can do many more functions themselves without needing the plan. And in general, there are less issues to address. So we've seen a decrease. Skip to the trend in call center and net promoter. Yes. So this is something we're really, really proud of. Net promoter score is something that the plan adopted several years ago, and you can see the evolution. And you see that NPS score hit all-time highs in the prior quarter. NPS score essentially reflects whether people will recommend the plan to others, will not recommend, or actually recommend against it. So it's a very, very important measure operationally. You also can see here that one of the reasons that an NPS score is high is because we resolve the issues 93% of the time. You may ask, well, why not 100% of the time? Because sometimes it's a benefit package, right? It's what the state tells us we can or cannot provide. And some people are dissatisfied with the package. But 93% is a very, very impressive number. Next slide. You'll see this was for the call center. You'll see that we are actually doing really well on Net Promoter Score across the board, across the entire company, not just the call center. We are measuring our patient member satisfaction in every interaction that we have with members. So then when we look across the board, whether it's medical management, sales, retention, and the call center, we're still doing extremely well. One of the key strengths that I'm very, very proud of is on customer satisfaction. So you see that our customer satisfaction is 4.7 out of 5. Again, absolutely not trivial to get those type of rankings, and 68% of the respondents actually qualify their experience as delightful. And then the last one, definitely not least, is highly rated employees. So average employee rating is 4.79 out of 5. Describing employees as 78% helpful and 70% respectful. So a while back, Mitch set one of the system goals as improving the experience of our patients and our members. And this is something that we really, really have been focusing on, and I'm very proud to report on this progress. Thank you.
Comments, questions? Fabulous report, thank you. All right, our last, IT. Dr.
I know we're
Mendez.
at time, so we can stay on this slide for a second. I just wanted to thank everybody, the board, for allowing us to do our cybersecurity presentation last Thursday. This is Cyber Awareness Month, and we've had a training going out across the entire enterprise. We can go to the next slide. Within this report, you will see an update on DNA and AI and DIS. Of specific note, our AI service line is actually building out. We have developed structures around governance, an intake process, process where we can review both any contracts as well as how does that fit in with our prioritization. And when it goes live, then we also are tracking that. Key areas that Divya's team has been working on is around revenue cycle, decreasing claims and increasing revenue capture, as well as working with Hillary Jalon for quality metrics and automating that process and making that less difficult to pull out of our system. And then coming on the horizon is ambient listening. The next bullet point is, you can go down a couple, thank you. You can keep going. Couple more. Okay, this is our Oracle Cloud implementation. This is one of our prioritized projects. This is actually moving us off of our old mainframe payroll and over to our new Oracle Cloud payroll and scheduling system. This is in the test period and phase 2 on track. We can continue forward. Actually, Mike, I'm going to let you do this this one here real quick.
All right.
Back one slide, please. Yeah.
What I'll attract your attention to here is the top right corner, the patient outreach. I think this is interesting. So we're looking across our system at patients that might be missing. We know that they're missing something in their care, like cervical cancer screening, and we will proactively reach out to that patient with a scheduling ticket, which is an open slot where they can book that appointment and through the modality that they would like. So this could be email, it could be MyChart, it could be text message, it could be what they prefer. There's a lot of examples within that, but I think it's the targeted outreach to our patients to get them the care that they need. That's the major advance here. You want me to do the next slide?
Yeah.
And then, yeah.
Yeah, this is a new training. Yeah.
Okay. This is interesting. So getting our providers, nurses, anybody to come to ongoing training has always been tough. We've done a good job of getting people to show up and take the initial training. That's been a success. But once you've been here for a few years, I think the showing up to ongoing training is not something that people are great at, nor are they going to read all the documents. What this does is very interesting. It goes through the record, meaning the electronic medical record, looks at the workflows that doctor or nurse actually use, and then delivers to them any changes to the content related to that with each upgrade. So this is like a personalized training that takes a few minutes that you can watch all within the electronic medical record. So this is, once again, a very targeted delivering of knowledge to our doctors and nurses. And I think it will really decrease the amount of time that they need to engage with training to get the maximal benefit. And Professor Drop is is our new character and our spokesman for this.
Right. And for those who are new, H2O was the name of our electronic health record. It actually stands for H plus H online, and not, even though water is essential, but that's really what the acronym stands for. So is our electronic health record. We can move to the next slide. And one more, please. And maybe one more. Okay, one more, sorry. Let's hang here for a second. This will actually tell the story. Each of these, this is very high level. It goes to central office. It goes more to the hospitals. It's specifically, we started tracking these numbers November of 2024 when we actually had our new contract for printing. And you can see that not only have we decreased overall volume, approximately 35%, our focus on the more costly printing around color has actually decreased across the system 63% and about 32% for black and white. So at our next presentation, we'll actually give a kind of a year in review, both with the next slide actually goes over similar savings from the cost perspective. And you can see just by saving from printing on color, you're decreasing volume, you're decreasing cost as well. And we can just go to the second to last slide. And in September, we actually had our EITS Stars of Excellence ceremony, and we honored 10 individuals across our system. And we'll close there.
Fabulous. Great. Questions, anyone? All right. Any old or new business? There being none, meeting is adjourned. Thank you all.
Thank you. Thank you.
This meeting is no longer being recorded. This meeting is being transcribed and summarized.